Welcome back, medical residents. Let's get right into today's clinical rounds. I'm your host, and in this explainer, we are diagnosing the invisible microscopic battles that are raging inside our patients every single day. We are looking at the absolute foundation of human disease, cellular injury. Because when a patient presents with symptoms in the clinic, what we're really seeing is the macro-level result of a microscopic struggle for survival. So grab your clipboards, because we are going deep into the pathology of the cell.
Here is our diagnostic game plan for today. We're charting the course of a cell's life under stress. We'll start with adaptive mechanisms, move into mechanisms of injury, check out invaders and immunity, look at the manifestations of damage, and finally conduct the postmortem on cell death. Let's get to it.
Section 1. Adaptive mechanisms of cells. Establishing the baseline.
Look at the progression here. We're tracking a baseline, normal epithelial cell to see exactly how it alters its size and shape just to deal with stress. First, it might shrink through atrophy to conserve energy, or maybe it bulks up, hypertrophy, to handle a heavier mechanical load. If it starts dividing rapidly, we get hyperplasia. But if the environment is just too toxic, it eventually deranges into dysplasia, which is completely atypical, chaotic cellular growth.
This brings us to metaplasia. Think of this as a reversible cellular identity crisis. A classic clinical example is the airway of a heavy smoker. Those delicate, ciliated columnar airway cells get chronically irritated by smoke, right? So to survive, the tissue literally swaps them out for tougher but far less functional stratified squamous cells. Sure, the tissue survives the smoke, but there's a huge trade-off. The patient loses a vital protective mechanism. Those tiny cilia that sweep away mucus and debris are just gone.
Moving to Section 2. Diagnosis, mechanisms of injury, tracking the breakdown.
Okay, if you take away one thing today, make sure it's the hypoxic cascade. Hypoxia, that sheer lack of oxygen, is the absolute most common cause of cellular injury, and it's usually driven by ischemia, meaning a drop in blood supply. So what happens? Well, without oxygen, the mitochondria completely halt ATP energy production, and without that ATP, the cellular sodium-potassium pump just fails. Potassium leaks out, while sodium and water freely flood right into the cell. This massively distends the endoplasmic reticulum and causes acute, catastrophic cellular swelling.
Take a close look at this internal structural breakdown. The real culprit here? Calcium. Normally, a cell keeps its internal calcium levels incredibly low, but during an ischemic injury, the plasma membrane is compromised and this lethal wave of calcium floods the cytosol. This excess calcium basically destroys the mitochondria beyond repair. Even worse, it activates proteases and endonucleases that literally chew up the cell membrane and the nucleus from the inside out. It is a total disaster for the cell.
Section 3. Pathology, invaders and immunity, the microscopic battlefield.
Let's size up our microscopic invaders. On one side, you've got gram-positive bacteria like Staphylococcus aureus. These guys are catalase and coagulase positive, meaning they can actually clot human plasma to build a protective shield around themselves. That makes them highly virulent and capable of triggering toxic shock syndrome. On the flip side, we face gram-negative pathogens like E. coli. Their primary weapon is an endotoxin found right in their outer membrane called lipid A, and that is exactly what can trigger life-threatening systemic septic shock.
So how do we fight back? Well, our innate immune system relies on pattern recognition receptors to spot the danger and rapidly deploy its first responders. Neutrophils are the absolute first boots on the ground at the infection site. Right behind them are monocytes that differentiate into macrophages, and their job is to literally eat or phagocytize the pathogens. Meanwhile, mast cells act as the local alarm system. They release histamine to increase vascular permeability and cause vasodilation, which throws the doors wide open for even more immune cells to flood the tissue.
All right, Section 4, manifestations of cellular damage, diagnosing the symptoms. Treat this like you're reading a patient's medical chart. It perfectly maps out the 4 exact mechanisms where a cell's waste management system totally fails, leading to abnormal infiltrations. You've got abnormal metabolism causing fatty liver, protein mutations that lead to defective folding, a lack of vital lysosomal enzymes causing complex substrates to build up, which is exactly what happens in Tay-Sachs disease, and finally, the ingestion of toxic, indigestible materials.
Now, remember that ionic pump failure we talked about earlier? Well, when that allows excessive extracellular water to chronically infiltrate the cell, our diagnosis is oncosis. This is a severely swollen degenerative state that we often call vacuolar degeneration. The endoplasmic reticulum literally ruptures and forms these massive water vacuoles. The cell is essentially drowning from the inside, pushing it right to the absolute brink of destruction.
And finally, Section 5, the postmortem, cell death, evaluating the final outcome.
So I ask you, residents, is this injured cell salvageable, or have we officially crossed the point of no return? And if we have, how did it die? Did it undergo messy inflammatory necrosis or the clean programmed self-destruction of apoptosis? Necrosis is invariably pathologic. It's an accidental, explosive death caused by severe injury. Apoptosis, on the other hand, is a highly regulated suicide cascade. It uses specific enzymes called caspases to quietly eliminate unwanted or irreparably damaged cells.
This visual perfectly captures that contrast. Look at the explosive, leaky, inflammatory rupture of necrosis over on the left. The plasma membrane is blown open, organelles swell up, and all those cellular contents spill out, triggering inflammation in the adjacent tissue. Now compare that to the neatly packaged phagocyte-ready apoptotic bodies on the right. The cell shrinks, the chromatin condenses, and it fragments cleanly without triggering any collateral immune response whatsoever.
But before reaching that point of no return, a stressed or starving cell might initiate one last desperate survival protocol, autophagy. Literally meaning eating of self, this is essentially a cannibalistic recycling factory. The cell builds a double membrane autophagosome to engulf its own cytoplasm and organelles, then ships them off to the lysosome for degradation. It is literally digesting its own internal structures just to fuel basic metabolism, recycle nutrients, and try to survive the stress. As we wrap up rounds today, I want you to consider this final diagnostic question regarding senescence or biological aging. We know that autophagy's cellular garbage collecting function becomes a lot less efficient as we get older. So if these recycling factories start failing to clear out misfolded proteins and those dangerous reactive oxygen species generating mitochondria over time, is biological aging simply the lifelong accumulation of these unhealed microscopic injuries? Are we really just the sum of our cellular scars? Think about that, residents. Until our next clinical explainer. Class dismissed.